Hello. Today we are going to be covering Chapter 20, Nuclear Medicine. I'll be the instructor for this chapter. My name is Tim Depinet, and I have been a nuclear medicine technologist now for the past 18 years. In nuclear medicine, we use radiopharmaceuticals to diagnose and to treat patients. These radiopharmaceuticals are usually injected, ingested, or inhaled into the patient. The procedure itself is usually relatively non-invasive. Usually a needle stick, an IV is about as invasive as it gets. Normally, small amount of radiation is used. Very few reported adverse reactions have occurred. We do use gamma radiation in nuclear medicine. We do also use beta radiation for the therapy side of it. So for more or less for diagnosis, we're going to use gamma radiation. If you look at the diagram below, you'll see the three forms of radiation that is used in medicine. The first one is alpha radiation. This one actually is probably the most damaging because of the fact that it can't really penetrate much. This is actually a piece of paper that is stopping alpha radiation. So if you were to ingest alpha radiation into your body, it would constantly stay in there and never be able to get out, so to speak, just because, like I said, if paper can stop it, your skin and everything else inside is going to be able to stop it as well, so it'll just stay there. So as I said up here, for therapies, we will use beta radiation. Now this one here can actually get stopped by a piece of aluminum. So with beta radiation for therapies, what we would do is, mainly for iodine therapies, we would give it in a capsule or a liquid form. The patient would drink it or swallow it, and then it would then concentrate up into the thyroid gland and then pretty much start to eat away at the thyroid gland to decrease its function, to get rid of any cancer cells, or whatever the reason is what it'll start to do. And then the bottom one here is gamma radiation, and this is mainly used in almost all of the rest of nuclear medicine. It is a very powerful radiation form. It actually takes about 4 millimeters of lead to stop the rays. This is good in nuclear medicine because the rays have to go into the gamma camera in order for it to generate a signal. So you need something that's going to actually penetrate lead a little bit. It's going to penetrate the crystal that's on the camera. So this would be the main type of radiation that is used in nuclear medicine. So as I had said before, the radiopharmaceutical is usually injected, ingested, or inhaled into the patient. It is detected by gamma cameras, by a PET CT scanner, by gamma probes, which will actually be used in lymphoscintigraphy studies, or by gamma counters, which can also be used for thyroid imaging uptake studies. The patient is actually the radioactive source in nuclear medicine, and it's not the camera. So what you would do is you would have the patient in front of the camera, and the radioactive rays would be given off by the patient, and the camera will absorb those rays to form an image. So the camera itself is not giving off any radiation. In nuclear medicine, we are mostly physiological, more so than anatomical. So in other words, we want to see how something is working more so, is it there or is it not? The benefits of the administered radioactivity is greater than the risk of the procedure itself. Obviously, in medicine, you always want to ask the question, do the benefits outweigh the risk? And in this situation, they definitely do. The benefits of diagnosing a patient with cancer, the benefits of diagnosing cardiovascular disease is far greater than the risk of the radioactivity that is actually administered. The type of radiation that we use in nuclear medicine is ionizing radiation. Obviously, the gamma and the beta radiation is included in that. In nuclear medicine, we try to keep things as low as reasonably achievable, or as we like to say it, ALARA. This means we don't want to overdose the patient. In other words, there are certain ranges per procedure that we're going to give. So like in the studies that I do for the myocardial perfusion imaging studies, we give it based on a patient's weight. So a smaller patient is going to get a lower amount of radioactivity, where a larger patient will get a little bit larger of a dose, just to get better image quality. But still, all of those dose ranges are going to be within a level that's going to keep things as low as reasonably achievable. The important thing in nuclear medicine are half-lives that we have. What those are, it just means whatever radionuclide is injected, the half-life, let's say, for instance, the technetium-99m, which is the most common that we use in nuclear medicine, once this is injected, every 6 hours, half of what was injected will just dissipate on its own due to radioactive decay. And what we like to say in nuclear medicine as well too is in order to achieve background, it takes about 10 half-lives to do so. So for technetium, with it being the 6 hours, we're going to say about 60 hours, and then the patient's going to be pretty much back to background levels. Thallium, which is used also was used a long time ago for all myocardial perfusion studies, has a 72-hour half-life. So the problem with a thallium dose would be you can't give as much because of the half-life being so long, because the exposure would increase in the patient. Now, the iodine 131, this is the one that's going to be used for most thyroid therapies. And if you can see on here, it's an 8-day half-life. I'm going to talk more about this later on in the presentation, but this is a big deal because there are going to be a lot more restrictions for that patient just due to the high level of radioactivity that they're going to be giving off. Here's an example of a card that we give our patients in our office after a myocardial perfusion scan. This is a card that we tell the patients to keep with them for about 4 days. What this is going to do is, let's say if they're trying to go into Canada or they're going to the airport or whatever the case might be, they have the potential to set off a radiation detection device. If they were to do that, of course, they're going to be stopped and detained immediately, but by presenting this card, this will tell the person detaining them why they are setting off their detectors. So on this card you can see the dates on there as far as when the procedure occurred, the patient's name will be on there, and then the expiration date. I usually put it out about 3 to 4 days, and on the back of the card it actually gives a little explanation as far as what's going on. The patient was diagnosed with, or had a diagnostic nuclear medicine stress test, was injected with so many millicuries of technetium-99 sestimib, which has a half-life of 6 hours. So this way, the person that will stop that individual will say, okay, I understand, this makes sense. And then also too, we have to have an emergency number on there of our radiation safety officer. That way, in case they needed to contact them, they could. I actually had a patient a few years ago that went down to an Ohio State football game and was across the street from the stadium at their little tailgating area. And some cops actually stopped that patient and started questioning him, saying, "Why are you setting off our radiation detection devices?" And the patient was like, "Well, I don't know." And he's like, "Oh, wait a minute, I just had a stress test yesterday." And so they said, "Okay, that's fine." So they called over to Ohio Stadium, where they actually play the game, and told the people, "Okay, this person sitting at this seat set off the detection devices. He's fine. You can let him in." I had never known that they had the devices down there, at the stadium, so it was quite fascinating to hear that. And of course, on Monday, we had to send paperwork down to the Columbus Police Department because at that time the patient left this card at home, and all was well. But that's why it is important to give patients a card like this. That way, in case they get stopped, this is their easy way out instead of having to go through a lot of questions. This slide's going to show you radiation doses from various activities that we would do throughout our lifetime, for that matter. Like say for the first one here, air travel. The average dose is about 0.01 for every 1,600 kilometers traveled. So if you went from New York to London, which I believe is about 4,500 kilometers, that's like 0.03 millisieverts per year is what you would get for something like that. You look down here at a chest x-ray, you're looking at 0.1 millisieverts per year. An abdomen CT scan is about 10 millisieverts. And then, nuclear cardiac scan is about 10 to 12 with just technetium based. Now, if you were to use thallium and technetium on like a dual isotope protocol, then that jumps up to 25. So you can see how powerful thallium actually is in nuclear medicine. And this is why we don't use it very often, because it does increase the dose per patient. And then also in this presentation, I'm going to talk to you a little bit about PET CT. And down here is a good example of a PET scan. You're looking at about 10 millisieverts per year is what it's going to be for that one scan. So if you were to put PET and CT together, because both of them will be done together, you're looking about 20 millisieverts just for that study alone. So, there are limits out there that the NRC puts on as far as what the average annual dose is going to be per person. People that work in the medical field, especially nuclear medicine, will definitely have a little bit higher limits than those that do not, but still within reason. As I said a couple of slides ago, ALARA as low as reasonably achievable. So this will definitely make sure that we're not going to overexpose ourselves as well. This is a topic that we take very seriously in nuclear medicine, and that's pregnancy. We must check with the patient prior to all studies. So when that patient comes in, before you inject any radioactivity or have them breathe it in or eat it or whatever, they have to be asked, are you pregnant? Is there any chance you are pregnant? If they say no, there's no chance, we can continue. If they say, there might be a chance, then a pregnancy test must be completed before the nuclear medicine study can be started. We do have signs posted in the waiting room and exam rooms. So when a patient comes in, there'll be a sign right at the reception desk that says, if there's any chance you are pregnant or breastfeeding, please let the technologist know. And again, as I say, we have to verbally ask. And especially prior to any therapies, women in childbearing years, they must have a pregnancy test before the administration of that therapy. And again, a few slides here later, I'm going to talk to you about the thyroid therapies and what the regulations are for breastfeeding and for pregnancy. But before any therapy, they must do a pregnancy test. This slide is going to show you guidelines that we have in nuclear medicine per procedure for breastfeeding. If you look at the first one here, the iodine 131, and again, this is mainly going to be used for therapies as well as some thyroid imaging, but there's going to be complete interruption. So in other words, they are going to make them stop breastfeeding completely, as well as the iodine 123. Mainly because since it is iodine, it's going to concentrate more on the thyroid, and with a young baby, those thyroid glands are constantly growing, so they don't want any risk of iodine going through the breast milk into the baby's thyroid to actually destroy it and then have complications later. Now, for say a stress test, we will use the technetium-99m sestimib. They tell us that interruption for breastfeeding must be for 3 hours if we only give 30 millicuries, or for 6 hours if we give 60 millicuries. Normally, for a myocardial perfusion imaging stress test, you're looking at probably anywhere from 40 to 60 millicuries. So if a patient comes in that is breastfeeding, we tell them stop it for 6 hours, pump anything that's out between those 6 hours, and just discard it. And then obviously for thallium, as I talked about before, since it is a higher energy radioactivity, the time's going to be a lot longer, so 96 hours or maybe even up to 2 weeks. And if a patient even came in for a bone scan, we would use the technetium MDP. There's actually no interruption in the breastfeeding schedule, so the patient can continue to do so. The one thing that I've actually noticed, though, by doing the myocardial perfusion imaging test, I actually have had a couple of patients that were breastfeeding during the procedure, and the problem that I ran into was the sestimib would actually accumulate more in the breast, into the milk, and my image quality would be very, very poor since the breast is obviously over the heart region. So we've actually had the 2 patients that I had done a test on, or attempted to, we actually had to cancel the test because we couldn't get a very accurate image due to the fact that the breast uptake was just so great because of the milk production. Okay, so what should the patient expect during the procedure? There usually isn't any pain or side effects associated with most studies. One thing that I've noticed is you might get a possible bitter or metallic taste sometimes when a radioisotope is injected. If the isotope is actually infiltrated or it's outside the vein, it will burn as it goes in. Like I said, it's usually tasteless, especially when it's given orally. So for gastric emptying study, if you're mixing it with scrambled eggs, you're not going to taste any radioactivity. If you're swallowing an I-131 capsule or an I-123 capsule, you're not going to taste that. There is some possible discomfort when acquiring the image. If you look up at this image up here in the corner, this looks like it could be a lung image, it could be a heart image, but the patient's arms are actually up above the head. In the myocardial perfusion world, while scan patients for 20 minutes in this position and having the arms up like this, it is very challenging for most. laying on a very narrow table. So, there is some possible discomfort when the images are being acquired. And also, too, there are some possible patient preps right before the study. So, again, in the myocardial perfusion world, we have patients stop caffeine for 24 hours. We have patients hold beta blockers for 24 hours. So there are possible patient preps before the study. And then some images can be taken immediately, right after the injection. Some have to wait a few minutes, and then others have to wait maybe even hours or days later. So it could be, a scheduling conflict for some patients if they have to come back a day or two later. But the number one thing in any type of healthcare profession is it is the duty of the healthcare professional to inform the patient of the protocol. The more that patient understands what's going to happen, the easier it's going to be for them. Even if you have to continually explain it throughout the entire procedure, it's very important to do so. The more comfortable we can make the patient during the procedure, the better off it's going to be. They are more likely to hold still, which gives you better image quality. And overall, by keeping the patient informed, it's just going to be a better experience for them. A type of study we do in nuclear medicine is a musculoskeletal study or imaging. It's to evaluate the distribution of active bone formation. As I talked about in one of the first slides, nuclear medicine is more about physiological than anatomical. Yes, we do know where we can definitely tell where the location is, but we're mainly going to tell, is it working or is it not? So for a bone scan, for instance, we are going to be injecting a radiopharmaceutical. It's usually technetium MDP. With a bone scan, we can do a couple of different studies. We can do a 3-phase bone scan, which means right when the radiopharmaceutical is injected, we start the scanning and we can get what they call a dynamic blood flow to that region. And then once, maybe 5 minutes after that injection, we would get what they call an immediate blood pool image. And we wait about 2 hours or so, and then we would get what we call the delayed image. That 2-hour wait will actually help clear out of the soft tissue and concentrate mainly in the bones. Another way we could do a musculoskeletal image or a bone study would be to use single photon emission computed tomography, or we'll just short it up and say SPECT. What this means is we will have the camera actually rotate around a certain region of the patient to get a three-dimensional view. Bone scans are mainly used for detecting and staging bone cancer, diagnosing occult fractures, diagnosing avascular necrosis, and for any of you that are sports nuts like myself, this is the Bo Jackson issue that he had with his hip, the avascular necrosis. The study can diagnose that, and also we can diagnose arthritis assessment. For bone scans, there are no patient prep protocols associated. The one thing that we tell our patients to do mainly would be to just drink a lot of fluids, especially after the injection. It helps to clear it out of the soft tissue, and we actually get better bone images. Here's an example of what a bone scan would look like. This would be the delayed 2-hour scan, so the radioactivity MDP was injected, told the patient go away for 2 hours, eat, drink, whatever you want to do, come back, and then these are what the images would look like. As you can see, technetium is cleared out through the urine, so you're actually able to see the bladder, which has a little bit of urine in. The patient probably did void before they went under the camera, but there's obviously a little bit of residual in there. The area right up here in the left anacube is probably the injection site. After the radioactivity is injected, a little bit of the residual will stick around in that part of the vein. Maybe a little bit of it went outside into the soft tissue. So more than likely, that's what that little area is. If you look into the shoulder joint regions, you can see little dark spots on both sides. More than likely, those are probably arthritic changes. And in nuclear medicine, this is what we're looking for in a bone scan, is we're looking for these little dark spots. And actually, I think there's even one down here on the left foot. You can kind of see it anteriorly and posteriorly. What we're looking for are these dark spots, which will represent active bone formation. Now, this active bone formation can occur after a bone has been fractured. This will occur during metastatic bone disease, or even arthritis. The bone's trying to rebuild itself. So that process is going to accumulate more of the radioactivity and thus shine brighter. This is an example of a SPECT 3D bone image. So what happens on this situation is, of course, the patient is still injected with the MDP. They wait 2 hours, they come back, and what they'll do is they'll put the camera over a certain region on the patient, and then they will run a 360-degree circle around that patient, taking pictures the whole time. This way we get an actual three-dimensional image. If you look at the bottom 2 rows down here, this is the one that's going to show that there actually is indeed an issue that's showing up on the spine. These images are actually sliced from front to back. You can see where the red arrow is and pointing to a small little dot that's actually on the spine. So this three-dimensional view, what it actually did was slice the vertebrae very thin from front to back, and you can actually see that there was a lesion inside. Not having the normal bone scan in front of me, we're not able to tell if we could see it on the regular bone scan image. There are chances that you weren't able to, but by doing this three-dimensional view and actually slicing the bones a little, you can actually see inside to tell that there is something going on. Now, this could be arthritis, this could be metastatic bone disease, this could be a fracture. Obviously, we wouldn't know because we don't have any patient history in front of us. Here is a great example of a bone scan with metastatic bone disease. You can obviously see all the uptake areas on the bone that would represent metastatic disease. The bladder is still right here, so that wouldn't be an issue. But here on the pelvis, you've got all on the spinal column, ribs, the arm. So obviously you can tell that this patient does have metastatic bone disease. There's the primary could be breast, it could be prostate, that it just spread to the bone. They could use a scan like this for staging cancer. Maybe the patient had this done a year ago and it didn't look anything like this. They could say, okay, the disease is spreading. We can stage it from a stage 3 to a stage 4 or whatever the case might be. Oncology scans are used in nuclear medicine as well. The most common are bone scans and PET scans, and they're used to detect metastatic disease. They're used to stage tumors. They're also used to evaluate the response to treatment such as chemo or radiation therapy. PET imaging is used usually with F18 FDG. It's very sensitive for detecting, staging, and monitoring treatment for malignancies, and it's usually combined with CT. So PET CT, with those two combined, PET is more of the metabolic information that we're going to get, again, the functional side of it, and CT is going to pretty much be the anatomical information or the anatomy side. Also in oncology, we can use indium-111 pentriatide, and this is mainly used to localize neuroendocrine tumors. Another scan that can be done in oncology for nuclear medicine is lymphoscintigraphy, and this is used to identify sentinel node or lymphatic draining in melanoma and or breast cancer patients. Here is a great example of a PET CT image. On the far left column here, this is where the CT scan would be. Here is the PET scan, and then here would be the combination of the two. This would be considered a normal study. So, and then over here would be just your scout images and your scout views from the CT and the PET scan. Here is a good example of a PET CT with metastatic disease. So again, here is the CT image, here's the PET image, and here's the combination of the two. So what they would do is they would just superimpose the PET image onto the CT image to get this view, and then they can tell exactly, okay, on this organ here, there's a lesion that is shown in the PET scan, but obviously it's not really showing in the CT scan, but they can localize it a lot better, and this way they can pretty much stage the patient, or if they needed to do therapy, they can pretty much pinpoint exactly where that therapy needs to occur. So here's an example of an indium-111 pentriatide scan. Again, this is used to localize neuroendocrine tumors, and you can see that these scans were taken over a few month period. You can see on the first slide here in the thyroid area there is an uptake, and then over the last couple of months it does seem to decrease. But then another problem spot is where this arrow is pointing in the abdomen. You can see there's an area of increased activity over the last couple of months, which would indicate another site where tumor is forming. Another oncology scan in nuclear medicine is a lymphoscintigraphy. Lymphoscintigraphy is actually used with the administration of 99M technetium attached to a nanocolloid, which are like very small particles. Usually what happens with the lymphoscintigraphy study is, let's say if it's in the breast, that's on the example down here below, if there's a spot in the breast, right in this area here, what they would do is they would do usually 4 injections around that site of this technetium nanocolloid, and what that will do eventually is filter into the lymph system. With this injection, I have seen a couple of these. There definitely is some stinging and burning once it's being injected. Again, since it is outside of the vein, as I had mentioned a few slides before, some stinging and burning will occur. The patient then is imaged anywhere between a half hour to 4 hours before the surgery, and then this way they're actually going to be marked. So what they'll do is they'll put them under the gamma camera, and then they will look for an actual node. Let's say if it's in this area here, that will light up. They'll light that up, and then they'll actually put like a marker on the skin to say, okay, this is about the region that we're looking. And then once the patient goes into surgery, then they would use an actual gamma probe, and then they would actually locate that hot node, which probably will be the sentinel node, and then they would actually be able to remove that. The endocrine system is another system studied in nuclear medicine. Thyroid scintigraphy is probably the most common study done in endocrinology. It is mainly used to visualize the general structure of the thyroid gland. Now, to do this, usually what patients will have is what they call a thyroid uptake scan. The uptake will actually show the function of the thyroid, and the scan showing the actual anatomy of it. So the first thing a patient would do, they would come in the office, you would give them a capsule of either iodine 123 or iodine 131. They would swallow it, wait a little while, and then they would measure the thyroid gland to see how many counts the radioactivity is coming off of the gland. Usually this is done to help to diagnose hyper or hypoactivity, and also to assist to differentiate Graves' disease from a toxic nodular goiter. For the scan part of it, like with the images up here in the corner, you can see these were all done by injecting 99M pertechnetate into the vein, which then will accumulate into the thyroid gland, and then we can scan it with a pinhole collimator. Another scan done in endocrinology is a parathyroid scan. This is usually used to localize hyperfunctioning parathyroid nodules, such as adenomas or even hyperplasia in primary hyperparathyroidism. And then another scan that we could do is iodine 131 therapy. I will talk more about this in the therapy section of this chapter. Here's an example of a thyroid scan in nuclear medicine. You can see the actual thyroid gland itself down here in the corner. Looks like these are just different scans of the thyroid. And then up here in this left corner, you would see an actual pinhole collimator. The way this is designed is the thyroid gland would be down in the lower part here. This is the little opening of the collimator. The radioactive rays will go through, hit the crystal up top here, and then form the image. By having a pinhole collimator, what it will do is actually magnify the thyroid gland, since the gland itself is very small. Probably the most common scan in nuclear medicine is the cardiology scan, myocardial perfusion imaging. This is done to assess blood flow into the myocardium. Usually it detects significant blockages of the coronary arteries. Now these significant blockages are going to be probably about 50% or greater that it will detect. Anything less than 50% will not be detected by a myocardial perfusion scan. And also too, let's say if there was a 40% blockage in the coronary artery, the cardiologist will probably not do anything invasive anyhow to fix that. Usually they don't do any angioplasty or stents with anything less than 50%. They'll just try to treat it medically, and if it does get worse, then eventually they could go in with an angioplasty and stent and correct it. MPI studies are used with a treadmill or a chemical stress test. Chemical stress tests can include persantine, dobutamine, adenosine, Lexiscan. Those are the 4 main chemical stress tests that were used in this type of a test. Patient prep is very important with this type of a scan. Holding certain blood pressure medications, especially for those patients that are going to walk on the treadmill, is very important. If they're on a beta blocker, that needs to be held for at least 24 to 48 hours. Another very important patient prep is the holding of caffeine for at least 24 hours. Anytime that we do a chemical stress test, if a patient has had caffeine within that 24-hour period, we're not able to complete the test. We would have to actually reschedule them. The caffeine will prevent the vasodilators that are used in the chemical stress test to actually work, so there's no way that we can actually perform the test if there's caffeine in the system. Another scan done in the cardiology field is the multi-gated acquisition, or MUGA scan. This is done to assess left ventricular function. This is going to give you what you call an ejection fraction. It's how much of the heart squeezes during the systole, or the contraction part of it. This is a really good study to do pre and post chemo patients, because sometimes the chemotherapy can actually affect the squeeze of the heart. So you want to do it pre-chemo, get a baseline reading, and then do it post-chemo to see if it actually did affect the squeeze and the contractility of the heart. Here is a great example of a normal myocardial perfusion image. So if we zoom this up a little bit, you can see it a little better. What we do is we will take two sets of images of the patient. The bottom row of each set are actually the resting images down here, and then the top row of each set are going to be the stress images. So what we do is we'll do the resting images first. So we'll inject the 99M sestamib or cardiolite into the patient. We wait about a good 45 minutes to an hour, and then we'll take the first set of pictures. That'll be our resting image. What we're looking at on these images is specifically the left ventricle. So as you can see, the left ventricle, inside where the little circle is, this is actually the cavity of the heart. This is where the blood's going to sit. So this would be the short axis view that we're looking at. This wall is the septum, this wall is the lateral, this is the anterior, and this is the inferior. What we're looking at is actual blood flow into the left ventricle of the heart through the coronary arteries. Now, if there is blockage in the coronary arteries, it will not get into the muscle of the heart, the myocardium, and thus that myocardium will not light up and be bright like these images are. So this is considered a normal MPI study. The top row are the stress images. What that's going to do is it's going to show us pretty much the blood flow into the myocardium under stress, be it chemically with a vasodilator or dobutamine, or on the treadmill. What happens, let's say if this patient was on the treadmill, they would exercise, we would inject another dose of cardiolite while they're exercising. Once their heart rate is above 85% predicted max, that goes into the myocardium at that moment and stays there. We have up to at least 6 hours after that injection to scan to see how the heart looked at stress. So on these images here, you can see it's nice and bright. The circle fills in beautifully. Even on the images down below, everything looks exactly the same from top to bottom. And this is what you want to see. You want your stress images to look exactly like your resting images. And in this situation, this is a completely normal myocardial perfusion scan. Now, here is an example of an infarction on an MPI study. Again, as I said before, the top row are your stress images, the bottom row are your resting. So what we're looking at are areas of decreased uptake or activity. And if you look here on the septal wall, this is the horizontal view, and actually you can see it up here in the short axis view as well. You can see the septal wall, how it definitely is decreased in activity. Compare it. Here's your lateral wall, here's your septal wall. And you look on both scans, it's exactly the same. So this is telling me that there's decreased blood flow to that part of the heart at stress and at rest. If it's both, then that's a good indication of an infarction, meaning that there is permanent blockage, that the muscle has been affected, be it a scar. So there's really not much that can be done to fix an infarction. It's like I was told one time, dead meat don't beat. Unfortunately, I know that's not very proper English, but it's true. Once it's dead, it's dead. It's like any other muscle. Once that muscle is dead, there's really no way of reviving it. And then also on these images, if you look down here at the apex, This is the vertical long axis, and if you look at the apex up here in the horizontal axis, you can tell it's just pretty much non-existent. That's another great indication of an infarction that occurred. And again, this part of the heart is not getting the blood flow because of the fact that it's been infarcted, and thus it is dead. Now, this is the main reason why we would do an MPI study, is to look for ischemic changes in the myocardium. Ischemic changes obviously indicate blockages in the coronary arteries. Those blockages are significant enough that needs to be in some form of intervention, be it an angioplasty stent or be it bypass surgery. So if you look on these images here, we'll look up at the top row here. Here are your stress images. Here are your resting images. Again, you want rest and stress to look the same. If you look up here in the rest or the stress images on the lateral wall, it's decreased activity. But if you look at the resting images, it's increased activity. So when your stress images are worse than your resting images, and that reversibility will indicate ischemia in the coronary artery. So there's blockage there that needs to be addressed. And when it shows up in an MPI study, it's usually considered a critical lesion because it's going to be greater than 50%, and thus it's something that needs to be addressed, and intervention has to occur. Here's another, it's the same view. Again, it's your lateral wall, just a different angle. Decreased activity at stress, normal activity at rest, that reversibility. There's definitely ischemia there, and there's definitely a need for intervention. Pulmonary scans are another big scan that is done in nuclear medicine, especially with the ventilation perfusion scan, or VQ scan. This is used to help diagnose pulmonary emboli. Usually what happens, a patient comes in, expressing chest discomfort, chest x-rays come back negative, then they'll want to do a VQ scan to make sure there are no blood clots that could be causing these symptoms. For the ventilation part of it, it's usually done with 99M technetium DTPA, or they actually use 133 xenon gas as well. They will actually inhale the gas to form the image. Again, there's no harm to the patient in this. It doesn't taste funny. It doesn't smell funny. It's breathed in to the lungs, and then we can actually image it at that time. Once the ventilation scan is complete, then we will do the perfusion scan, and that's usually done with 99M technetium MMA, or macroaggregated albumin. Again, these are very small particles that are injected. It goes into the lung via the perfusion side, and then they can compare the perfusion with the ventilation. For the perfusion, you want the count rates to be 3 times higher than what it was for the ventilation. If you're using technetium DTPA for the ventilation, you want the perfusion to pretty much overtake the image. That's why you want to go 3 times higher for that injection. Here's an example of a VQ scan. This is a normal scan. The first image here is the ventilation of the anterior view, and this is the perfusion of the anterior view. Again, just like the myocardial perfusion imaging, you want both sets to be exactly the same. And in this situation, they are. Here's a posterior view of the ventilation, posterior view of the perfusion. And again, all of these are completely normal. They both look the same. Now here's an example of a positive VQ scan for pulmonary emboli. If you notice, here's the ventilation, and I'm assuming that this is it almost looks like it's a posterior view. So here's the ventilation scan, and then here's the perfusion scan. What you're looking for are these chunks that are missing out on the perfusion scan that are not missing on the ventilation scan. So here's a nice chunk. It's usually in the form of like an arrow. It starts in the inside and then fans out. That is a good indication of a pulmonary emboli, even down here as well, where the ventilation scan is completely normal. So this patient will definitely be diagnosed with pulmonary emboli. Renal studies are also completed in nuclear medicine. They're done to evaluate renal function, to evaluate renal obstruction, to evaluate any reflux, and also as renal transplant assessment. Patient prep for this type of a study is just for the patient to be well hydrated. The agents used in this type of a study are 99M technetium DTPA, which is usually eliminated by the glomerular filtration, as well as the 99M technetium mag3, which is eliminated by tubular secretion. Gastrointestinal scans are also a common scan done in nuclear medicine. Liver spleen imaging, gastric emptying study, and even hepatobiliary imaging. For the liver spleen imaging, what they usually do is to determine the size and shape of the liver and spleen. They would use a 99M technetium label to a colloid, such as a sulfur colloid. Again, those are small particles. They go into the liver, into the spleen, so that they can visualize the size and the shape. Gastric emptying study is done to see how well the stomach is functioning, to see how well it's emptying. Usually what happens is they will use a food and they'll mix in the 99M technetium sulfur colloid, usually scrambled eggs. They'll scramble up the eggs, they'll inject a little radioactivity in there. The patient will eat the eggs, and then they'll just lay under the camera for about an hour or two, and they'll just watch how quickly it actually goes out of the stomach. It evaluates the motility as well as the gastric motor functions of the stomach. Hepatobiliary imaging is used to determine the function of the gallbladder. This is also known as a HIDA scan. With the HIDA scan, they would inject a radioisotope, and then they would lay under the camera for about an hour to watch the gallbladder fill up. And then after that hour, they would normally inject something called CCK, or cholecystokinin. And what that does is it actually contracts and squeezes the gallbladder to see how well that is functioning. A lot of times patient will come in with a gallbladder that's not functioning properly. They have all the symptoms, but until you do a test like this to really tell how it's functioning, there's really no way of knowing. A patient could be completely clean of stones, but if the gallbladder is under functioning, then they're going to have the same symptoms as if they did have stones. So with the administration of the CCK, there can be some discomfort. Depending upon the protocol. I've seen protocols that they inject the CCK for 3 minutes. That usually makes a patient feel nauseous. It gives them some contraction, some abdomen pain. And then I've also seen a protocol where the CCK is administered over a 20-minute period, and there are very few, if any, side effects or symptoms, and it actually does the same thing. It just takes a little bit longer. Here's an example of a HIDA scan. This I'm going to assume is probably an hour-long image. You can see the gallbladder starting to fill up on the first frame, and then it just keeps getting brighter and brighter with each frame. And then actually you can start to see how it empties out into the common bile duct. One thing that I'm noticing on this one, and it didn't say when I pulled the image up, is the radioactivity stops. You can see how it forms a little ball down in here. This little juncture is actually the sphincter of Oddi, which connects the common bile duct into the small intestines. A lot of times there will be an issue with the sphincter of Oddi as far as not opening properly. For a situation like this in the HIDA scan, what they can also do is inject morphine. What that does is it actually relaxes the sphincter of Oddi, and then that should empty out, and then you should be able to see that go into the small intestines. I don't know if they did that on this situation, but based upon how things look, and I'm guessing they probably did. So this type of a test, again, what it's going to do is going to show you the function of the gallbladder, making sure that it fills properly and empties properly for normal digestion. Neurology is another scan that is done in nuclear medicine. You can use SPECT and or PET images that are normally used to assess cerebral blood flow. They're used to assess dementia and actually to locate epileptic foci. Usually the radioisotopes that are used are 99M HMPAO or 99M technetium ECD, which are mainly used for those two are mainly used for SPECT testing. Now, if you wanted to do PET, you would use fluorine F8 or F18 FDG, which would actually give you those images. If you look at the brain scan right down in here, you can tell this side has more uptake than what this side does. That's kind of what they're looking for when they do a scan like this. They want to check perfusion. Both sides should be symmetrical to each other. This left side should definitely be the same as the right. In this situation, it isn't. So there is obviously a situation going on. PET-CT imaging is very common in nuclear medicine as well too. As I talked about earlier, it's definitely used in oncology, but it's also used in neurology as well. The PET part, or the positron emission tomography, is usually there to help to show the functional or the metabolic information of an organ tissue. It helps to diagnose the presence and the extent of a disease. And then the CT part of the computed tomography, is the anatomical part of it, which helps to locate an area. So the PET's going to show you the function, the CT is going to show you the anatomy, and put them both together, and that really gives you a good picture of the organ system that's being imaged. As I said, together they can help pinpoint the exact location of interest and determine its functional state. Now I want to talk a little bit about patient exposure and patient prep for a CT, a PET CT image. If we look at the PET part of it, up here, the F18 FDG, this will be the PET side. It's a very, very short half-life, and as I had talked about earlier in this presentation, we're looking at about 110 minutes before half of whatever was injected will just dissipate and decay on its own. So the half-life is going to be very, very short for these PET radiopharmaceuticals. So thus, because of the short half-life, you're going to have a reduced radiation exposure for that patient. The overall, like I said, it's about a modest effective radiation dose of about 10 millisieverts. I had discussed this in a previous slide. It's probably equivalent to that of a myocardial perfusion imaging stress test as well. So I would say it's probably about average when it comes to the nuclear medicine world as far as patient exposure goes. And then the CT part of it, it can vary. The exposure anyhow, and the reason I say that is because it depends on the length of the CT study that's being performed. So, I mean, is it just going to localize something, or is there going to be high resolution that's going to be needed, which will take a little bit longer? So, and again, on the radiation exposure dose to the patient, you're looking at about 10 millisievert as well for an abdomen CT. So when you combine them both together, you're looking at about 20 millisieverts. That's probably on the higher end of normal for a patient exposure rate. I mean, you wouldn't want to have this test probably done once a month, maybe once every 6 months, once a year kind of a thing, just to keep your exposure limits down. Patient prep is going to be very important with something like this. You must follow in order to get the most optimal image. And then after the scan, the patient is safe to be in the public. With any nuclear medicine procedure, it's best if you can limit your contact with children and pregnant females. It's not mandatory for this. It's just, if you can, great. If you can't, well, then, just kind of don't stick around too long. Don't hug them for a long period of time. Don't sit right next to them. Maybe, a couple feet away, and everything should be just fine. But again, because of the short half-life of the F18, it's not going to be in the system very long at all, so the exposure toward other people will be very minimal. Therapeutic nuclear medicine is one where we will really have to focus on the patient prep, the restrictions post-therapy for patients and for the public, just because we're going to be using pretty high doses of a radiopharmaceutical for the therapy. Most common therapies in nuclear medicine, you're going to have your thyroid therapy, to help treat an overactive thyroid, to help treat cancer. Patient prep's going to vary for each of these, and there definitely will be some restrictions post-procedure. Another type of a therapy in nuclear medicine would be pain relief therapy. This would be used for like bone met disease, arthritis, and with this type of a therapeutic procedure, there will be no patient prep whatsoever for this. Here is a great example of patient restrictions following a thyroid I-131 therapy. And for this therapy, the dose range was between 16 to 33 millicuries. I would say in the therapies that I have done in the past, that's probably going to be your average range. But if you look at it, avoid sharing items by mouth, such as eating utensils, straws, things like that for at least 2 days. Here it says to avoid pregnant females for at least 11 days, sleeping alone for 11 days, avoid even kissing for a couple of days. So you can see that there are plenty of restrictions, and they're fairly lengthy, especially with the pregnant females and with the young children. If you look towards the bottom here, even preventing pregnancy. So if a female in childbearing years decides they're going to have a thyroid therapy, they don't want them to get pregnant for at least 6 months after that therapy. And then, of course, down at the very, very bottom here with the breastfeeding, they want you to stop that immediately and pretty much not resume it for the whole duration of the child, breastfeeding years. just because, again, with the thyroid, obtaining the iodine, and especially with babies and little children's thyroids constantly growing, you don't want to risk having an overexposure to a growing, developing thyroid, which would stunt the growth, and then you would have issues long term down the road. So these are just some common restrictions that they're going to give for thyroid therapy. Obviously, the higher the dose up here, the longer these restrictions are going to be, from maybe 2 days instead for the kissing and the sharing things by mouth to maybe 7 days, and maybe up to 2 weeks for sleeping alone and avoiding pregnant females and children. So like I said, it will vary the higher it goes. So if a patient were to come in that is scheduled for a therapeutic nuclear medicine procedure, the most important thing you can do as a technologist is to communicate with the patient before, during, and after the study. You want to give them every opportunity to do exactly what is right. So if they are to stay away from children for 11 days, they need to know that. You need to reiterate that. You need to give them every opportunity so that they do stay away from those children. And then before giving any therapy, a nuclear medicine tech must review the appropriateness of the study. They need to check to make sure that the patient prep has been followed. They need to check for patient consent. Before any therapy, the patient must consent to say, yep, I'll have this done. I understand the risks, the benefits, and they have to sign off on it. So then once that consent has been signed, then the technologist can go through with the therapy. And then, of course, the biggest thing, you have to explain the procedure to the patient. My philosophy is treat that person the way you would want to be treated. So if you're sitting on the other side of that table getting ready to swallow a radioactive iodine therapy tablet, then I want to know exactly what's going to happen to me. So then you need to treat that patient accordingly and let them know exactly what's going to happen to them. So as I have down here, the bottom line is communicate. Just be open, explain it in detail. That way the patient understands. If they don't understand, then explaining a little bit longer, a little bit slower, a little bit more in detail, whatever the case might be, just to get them comfortable that they know what's going to happen once the therapy gets started. So obviously this is not what it looks like once we start a therapy. This is not what it looks like once we start a nuclear stress test. Whenever you hear nuclear medicine, we don't make bombs. That has nothing to do with the mushroom cloud. This is not why we're in this field. So this is just kind of a joke, but it's something that the public needs to understand, that nuclear medicine, yes, there are some risks that are associated with it, but as I talked about in one of the first couple of slides, the benefits far outweigh the risk. This is really what it all boils down to right here. It's the care that we give to our patients, so that way when they're going through a procedure, they're comfortable, they're knowledgeable, they understand everything that's going on, and that we must take our time to explain these procedures to these patients in detail so that the patients are comfortable and are willing to go through with it. So the number one goal of a technologist is definitely patient care. And this is why we're all here. This is why we do what we do, because we love helping people. And this is just a good example of that, just being there for the patient, giving them the care that they need. So that concludes Chapter 20 for nuclear medicine. If you have any questions throughout this lecture or afterwards, please feel free to email me. My email address is timothy.depinet@mercy.edu. Or if you want to get a quick question in and you need to call or text my cell phone, my number is 419-306-0529. Thanks again, and have a great day.